So I'm Rachel Culver, and this is my case report, and it's on the efficacy of trunk stabilization exercises in for a stroke patient who also has MS. Basically, patients with MS are referred to physical therapy often for trunk stabilization. Patients with stroke are also recommended for physical therapy for trunk stabilization purposes as well, among many other things for both patients. There's good support in research for trunk training in both patients, one with MS, one with stroke as well. But there's really not a preponderance of evidence, or really there's a lack of evidence for doing trunk stabilization training in a patient who has both MS and who has suffered a stroke. So the purpose of the case report is to evaluate the effectiveness of trunk stabilization in a patient who has subacute stroke and has had MS for him a long time. So just briefly, multiple sclerosis, it's a chronic inflammatory demyelinating disease of the central nervous system. It is classified as neurodegenerative and autoimmune. The diagnosis usually made between the ages of 30 and 50. 75% of patients who have MS survive for 25 years after their initial diagnosis. It has a 2-to-1 ratio in females to male, and there's 4 types. Relapsing remitting is the most common. It's about 84% of the cases, and it is the case for my patient as well. Medical management of multiple sclerosis includes disease-modifying drugs like interferons or copolymers, and that's taken on a regular basis once they have been diagnosed with multiple sclerosis. And then anti-inflammatories, mostly corticosteroids and glucosteroids for the acute periods of inflammation that happen during a relapse. The risk of that medication, the risk and benefits actually, the benefits first are that the disease modifiers do tend to slow the progression and kind of diminish the effects of the relapses as they happen over time. And then the corticosteroids also they stop the inflammatory process kind of in its tracks so that things can start to calm down and the person can start to recover from that relapse. They do come with risk though, and that is over time, blood glucose levels change. There's changes in blood platelets and overall a complete blood count for those patients. Overall immune system suppression, which is never good, and then high risk for cardiovascular diseases. The normal risk and side effects of taking their medications include flu-like symptoms. That's very common in the interferons and basically the injections that are taken either on a daily or a weekly basis. A lot of patients suffer from flu, and it's not flu-like symptoms and you feel better the next 24 hours. It lasts just like the flu does, and it feels just like the flu. Type 2 diabetes develops over time commonly in patients with MS due to the glucose or the steroids, and then cardiovascular diseases, a lot of them. The way that multiple sclerosis works is that a very high level of inflammation in the body caused by a pathogen or just the disease progress itself creates cytotoxicity of T cells that cross over the blood-brain barrier, and they affect the myelin sheath on the nerve axons in the brain and in the spinal cord. The way that the disease progresses and that the way that a person has impairments is that the sites of myelin damage will either recover, especially in relapsing remitting, or they won't, and sclerotic plaque is laid down in that place. So the destruction of myelin results in slowed nerve conduction, motor dysfunction, sensory impairments, and often visual changes. Trunk impairments are a result of both motor dysfunction in a sense of having the strength to hold yourself up using your trunk musculature. So the muscle weakness is under the motor dysfunction, as well as sensory impairments. So proprioception is often lost. The person's perception of upright is lost, and then also just what they're sitting on and what it feels like is changed. Balance is in both of those, basically. So for being referred to physical therapy, MS patients come for strength, for endurance training, for balance training often, and a lot of times just for the overall maintenance of whatever level of function that they happen to be at, to maintain their independence, and then prevention of secondary impairments like contractures, and if depending on the progression of the disease, if the person is in a wheelchair or often supine, then pressure ulcers as well. And then safety, and safety is mostly because of fall risk when balance is impaired. So for strokes, there's two types, ischemic and hemorrhagic. Ischemic are the embolic or the thrombotic. Ischemic is the most common. It occurs in 80% of all strokes. It also occurred in this patient as well. Hemorrhagic are ruptured aneurysms. Strokes are the third leading cause of death in the United States and the number one leading cause of disability. And about 700,000 initial strokes, so first-time strokes, happen every year, and 500,000 subsequent or follow-on strokes in the same patients happen every year. So there's an estimate of about 5.5 million stroke survivors living in the US. And on average, it is every 4 minutes someone has a stroke. Risk factors they vary across demographics as far as race and ethnicity go. But common risk factors are increased with age over 65 years. Hypertension, the risk is increased by about five times that of the general population if that blood pressure is over 160/90. Any heart disease or history of heart disease, and then diabetes as well. Signs of stroke: sudden numbness, weakness, especially in the face, arm, and leg on the same side of the body, any confusion or visual changes, dizziness, and loss of balance or coordination. And in that case, you need to get the person to the emergency room immediately. The medical management of a stroke, first and foremost, is to increase and restore the oxygenation to the brain. That is done by giving the person oxygen through a face mask or whatever they, on whatever percentage they need to do. Maintaining appropriate blood pressure. So you need higher blood pressure for following an ischemic stroke in order to reperfuse the brain with blood, and then lower blood pressure for hemorrhagic in order to prevent a follow-on stroke that happens very soon after the stroke. Restoring fluid and electrolyte balance, and then maintaining the cardiac output, intracranial pressure, bladder function, and skin integrity are all management for stroke while the person is in acute care. Primary impairments for stroke: sensory issues with pain and visual changes, motor function, including flaccidity and spasticity, reflexes, muscle weakness, change coordination, and motor programming. Postural control and balance, you can see all of these. I don't need to read them, but all of these are primary impairments, and the secondary ones include seizures, hydrocephalus, cardiovascular impairments, DVT, pneumonia, ulcers, and other skin breakdown. So patients who suffer from stroke are referred to physical therapy for a vast number of reasons: strength and endurance training, balance training, regaining their coordination that was lost, reorienting the person to upright in many cases, and then their proprioception and other sensory losses that have taken place. PT, physical therapy, also prevents and treats, or helps to prevent and treat, secondary impairments of stroke, which include the deconditioning, pressure ulcers, and something got deleted, pneumonia, and illnesses that happen like in the hospital, so mostly pneumonia. So for this case study, he's a 78-year-old African-American male. He was retired from the Air Force. He had postgraduate education. He was a psychologist. He has an over 60-year history of 1.5 packs per day smoking, a 40-year history of relapsing, remitting multiple sclerosis, and then a confirmed right CVA in November of 2015. He was admitted to the hospital for all of the sudden signs of stroke that were listed before, and then admitted to the subacute rehab facility where I was for CP2 in December after 2 weeks of acute care. The initial tests and measures that were used, the PPNME, it's very similar to a FIM score, and it measures bed mobility, transfers, multiple stands from chair, standing balance, and ambulation. And that's literally, it's just listed in the electronic medical record system that they use. And each section is scored 0, 1, or 2 for a maximum score of 12. It has very high inter-rater and intra-rater reliability. And it's, like I said, it's built into Rehab Optima. And so at the skilled nursing facility where I worked, it's just something that when you select certain things about your patient, it's one of the automatic outcome measures that populates. So what I'm saying is I didn't choose it. The trunk impairment scale is commonly used post-stroke. There's 17 items. The subscales are basically for sitting, static and dynamic balance and coordination. You can get a 1 or a 0, 1, or 2, and then in some cases a 3, and the maximum points on the TIS is 23 points. Has very high intra-rater and inter-rater reliability and has been validated at a high level and was done so a long time ago. The only drawback to the TIS is that if the patient is unable to perform the first item, which is sitting unsupported, so they sit on the edge of a surface and they cannot have their hands down. And if they're unable to do that, then they're given a 0 on the entire exam. You can't move forward and try any of the other aspects of the exam. So the intervention for this patient. I broke up trunk control into 3 positions, and that was supine, sitting at the edge of the bed, and then standing in a standing frame. So supine trunk control training sounds very boring, and it is in our minds, but for this patient it was a lot of work. And so with MS you want to be careful about keeping everything sub-max, and when you're not tracking numbers, you're tracking the level of fatigue that the patient reports and feels, and what you can see from their power production, their coordination, and things like that. So while it sounds benign, it's very much a part of this intervention and was very necessary. So we did the initiation of rolling towards and away from his affected side, and like I said, he had a right-sided CVA. The left side, he actually had left side neglect and left side paralysis in a lot. It wasn't complete paralysis, but it wasn't even really it was a 1 out of 5 on MMT. So you could feel the intention to move a limb, but he couldn't pick his arm or his leg up. So initiation of rolling toward and away from his affected side, the use of the bed rails and his upper extremities to do that, and then segmental rolling. So we broke up rolling in upper body, left and right, and then initiating with his legs versus his upper body, and did that a lot. So if you can picture him trying to roll with just the leg and then coming back, trying to roll, doing the quarter rolls as well, and then half rolls and then full rolls. And then he got to the point where he could come to side lying on his own. Sitting edge of the bed was the second position, and his balance was challenged. Balance and strength, I should say, was challenged in a lot of ways, reaching outside of his base of support. So several times we combined his therapy with OT, and OT would be working the upper extremities as well as the PT doing, in our case, trunk stabilization. So he was reaching for cones, tapping the cones, and then in a couple of occasions with his unaffected side, grabbing an object and then bringing it to him, which was much more challenging. Leaning against resistance, so he would lean against my hands, and then I would take him away, and he would have to do his righting reaction to come back to upright, and then leaning laterally over a supported bolster. And the thought behind this was to have him go ahead and lean over a bolster, relax in that position, and then have to concentrically contract to bring himself up. So it's a lot different than just leaning over here and keeping and going in an eccentric fashion, holding it for a second, and then coming back up with a concentric contraction. We were starting with no muscle involvement once he relaxed on that bolster. And then also leaning forward and backwards to the extreme range of motion where he was already off balance, but this was like a couple of occasions he didn't appreciate this one at all, let's just say that. Okay, standing in the standing frame, his balance was challenged in the following ways. basically we would stand him and then have him lean across the table at first because he needed all the support he could get. And as we went, we would have him bring his hands back towards him to the end of, to the point where at the end of the 4 weeks, he could rest his hands in front of him on the standing frame table and have less support from the apparatus itself. Initially, when his arms were out in front of him, head being in the upright position was enough of a challenge. So bringing his head up and having him look out at a fixed object was enough. So here are the results. So rolling towards his affected side, so using his right arm to initiate the movement, a lot of times using the bed rails to pull, and then after a while just using the right arm and leg to roll. He went from max assist to min assist. And that min assist was more of a positioning than it was like doing the roll for him. Rolling away from his affected side and or bringing the left arm, towards the right was always challenging for him. He did get to a point where he could bring the arm across his body and set it down, but he just could not get enough force production for any momentum to be there to carry the rest of his body. Sitting edge of bed supported, so hands down. He was max assist at first. The therapist was doing most of the work of keeping him upright, and he would just, no expression on his face, he would just fall over. But he could tolerate it for about 7.5 minutes, meaning that orthostatic hypotension, those types of things were not an issue when he sat for that long. It became an issue of breathlessness and fatigue after about 7 minutes. 15 minutes with just supervision, hands down after that. So that was a huge improvement for him. Transferring from the bed to wheelchair and back with a sliding board was maximum assist before. It was mod assist in 4 weeks. And as you can see, sit to stand, it required two people to bring him to standing and then just one doing maximum assistance. Standing tolerance was about 10 seconds the first time we put him in the standing frame. And it was orthostatic hypotension. He did have the knee flexion contractures as well, so he wasn't that upright in the first place, but he was more complaining about discomfort and OH and breathlessness and things. It got to 3.5 minutes 4 weeks later, and we required him to talk to us while he was standing to regulate his respiratory rate, and that's while reaching for objects as well. And then MMT of hip flexion increased by 1. So when he went to side lying, you could see him bring his lower extremity up into hip flexion. Unfortunately, the outcome measures still a 0 for the PPN-ME and the TIS. The only outcome measure that actually improved was a 2 out of 5 on the MMT. So the question is, what the improvements that I'm seeing, are they real? Are they just observational findings that I'm seeing because I know he's doing better, he's participating more? Why can't we track any of these? And I would say that in this, one of the limitations was that the PPN and ME were not sensitive enough, and that one of the things to consider is maybe when we have a patient who has comorbidities such as MS with stroke, maybe things like bed mobility need to be broken down into going towards and away from their affected side. And that would have made a bigger difference on an outcome measure. Also, the need for it to, account for his tolerance. So timed tolerance for sitting and for being in the standing position, because both of those increased. The other thing that increased was it decreased was his level of assistance needed. So he was able to participate more in his own transfers, whether it was rolling or positioning in bed, including scooting, and then, which is important for pressure relief. Same thing in the wheelchair. He could push through his upper extremities. It was lopsided, but he could push through his upper extremities and reposition himself a little bit, not for the 15 seconds that you need for prevention of pressure ulcers, but he could not do any of that before the trunk control training. So these are things that I think would be beneficial to track the entire time. One way that they were tracked were through the goals that were written. So that's an objective measure that you can account for that was improved over the time in treating this patient. And then the limitations, like I said, PPNME was not sensitive enough to detect the changes in this patient. The TIS, like I said, it has that very low ceiling effect for number one being unsupported sitting, but his supported sitting, he made so many gains in supported sitting that were unaccounted for. And then the patient self-discharged against therapist advice at that 4-week mark because, like I said, he's a 60-year smoker and he could not stand being in a facility and he wanted to go home and smoke. And that was the entire reason that he left. It's kind of in line with, you know, a right-sided CVA, but as far as judgment call. But if he had stayed longer, I feel like he would have even made changes detectable by both of these outcome measures. Here's the references. Any questions?
I have a question. Did you try any of the other objectives on the trunk impairment scale, or once that one, the first one he wasn't able to do, did you just stop there?
No, we didn't stop there. We tried to do the other things, and he was able to accomplish a lot of the other things, including coming to sitting at the edge of the bed on his own, but he was supported. That's the thing. No, I didn't keep a score on the TIS. We just tried for those as if they were objectives, yeah. Yeah.
Were his MS symptoms ever a significant factor besides the fatigue?
Besides the fatigue, he had knee flexion contractures with negative, or he was lacking 42 degrees of extension. And so while he was there, he received Botox injections bilaterally, and we did do manual therapy, other strengthening therapies, or other strength training as well. But by the end of the 4 weeks, the contractures were at 28 and 29, left and right, so they were decreased after the Botox, and I think after standing as well, and all the manual stretching that we did. But other than the contractures and his he had spasticity, especially in the lower extremities, so sometimes that would come into play, but other than that, the fatigue was the primary issue. Yeah.
What was his prior level of function before he had?
Actually, his prior level of function, you know, before the stroke was worse than it was at the end of this 4 weeks, because he spent all of his time in a wheelchair at home with his elbows propped on his knees, and he has calloused knees and elbows from being in that position almost all day long, and could not right himself on his own. So someone would put him into his wheelchair at the beginning of the day, and then as his fatigue increased, he would kind of decline into this supported position on his elbows and then not come back up. And at this point, at the end of the 4 weeks, he could right himself on his own, sit in a wheelchair with his arms in a more neutral position. So his level of function prior to the stroke was very low, but there were things that he could do after his subacute rehab stay that he couldn't do before. Yeah.